So, hello everyone. Today we will be discussing about electrical muscle stimulator. Starting with the outline, it is used for the diagnosis purpose and for the therapeutic purpose. First, we will see a review of a polarization and action potentials. The stimulation requires a polarized membrane between inside and outside of the nerve membrane. More positive ions than negative ions outside nerve and more negative ions than positive ions inside the membrane. When polarized, membranes have a potential of minus 70 to minus 90 millivolt between inside and outside of the membrane. Here, as you can see, the unpolarized membrane, the polarized membrane, and the depolarized membrane. The nerve action potential eventually causes an ascending sensory impulse to the brain or a descending muscle action potential. Muscle action potential causes muscle contraction. Nerve repolarizes quickly. Absolute refractory period vary from 0.4 to 2 milliseconds. It depends on the specific nerve. Here, as you can see, there's a graph which shows the depolarization and repolarization and the threshold between them. As you can see, here is an action potential. Moving on to the diagnosis purpose of an EMS. It's used as an infrared galvanic test, the measurement of rheobase and chronaxy, the strength duration curve, the nerve conduction velocity studies and tests. First, we'll see the Faradic galvanic test. Faradic stimulus evoked no response in denervated muscles, and galvanic stimulus produced sluggish response. Based on various researches, it has been shown that the reaction to the Faradic galvanic test applied to muscles are correctively interpreted only in 50% of the cases. This test is inaccurate and unreliable. Moving on to measurement of rheobase and chronaxy. Rheobase minimum current for infinite duration in practice, 100 milliseconds or more, will cause a contraction. In chronaxy, minimum time for which a current of intensity twice rheobase will cause contraction. Both are increased in denervated muscle. These values are greatly varies with few variables like temperature, blood supply, electrode size, and the skin resistance. Now you can see the normal value of rheobase of different muscle. In deltoid, it is 14 volts to 5 milliampere. In tricep, it is 18 volt to 5 milliampere. In adductor digiti minimi, it is 13 volt and 8 milliampere. At frontalis, it is 40 volts and 4 milliamps. The factors affecting the rheobase: the resistance of the skin and the subcutaneous tissue, the edema and the inflammation, the ischemia and the underlying pain, the temperature and variation, the position of electrode, the amount of the subcutaneous tissue, the degeneration, the denervation. The partial denervation generally produce no changes in rheobase. Reinnervation can show a sharp rise in rheobase, which indicates the clinical recovery. We'll move further to the normal value of chronaxy of different muscles. Muscle group deltoid has a constant voltage of 0.01 millisecond and constant current of 0.1 amps. In adductor digiti mini, the constant voltage is 0.04 ms and 0.2 constant current. In tibialis anterior, the constant voltage is 0.04 ms and the constant current is 0.01 millisecond. Factors affecting the chronaxy. The factors affecting chronaxy are the texture of the skin, ischemia, the edema, fatigue, position of the stimulating electrode, denervation, partial denervation, re-innervation, any nerve root lesion, radiculopathy, any peripheral neuropathy, and myopathy. Moving on to the strength duration curve, which is also known as the SD curve. The SD curve is a graph between electrical stimulus of a different intensity and recording the time needed by each stimulus to start the response. SD curve should be plotted after 20th day of the injury or the lesion. After the 21st day, regeneration of nerve will start. Generally, it takes about 270 days to regenerate. The purpose of the SD curve plotting is to know whether the stimulated muscle is innervated or denervated or partially denervated. There are also other methods for this purpose like EMG and NCV, known as electromyography or the nerve conduction velocity. Now we will move further to the apparatus. The apparatus with rectangular impulses of different duration. Impulse with duration of 0.01, 0.03, 0.01, 0.3, 1.0, 30, 100, 300 ms are required. The stimulator may be of either the constant current or constant voltage type. The constant current stimulator has thought to produce a more accurate result, but constant voltage stimulator is rather more comfortable for the patient. Here's a strength duration curve. The SD curve is a graph representation of quantitative non-linear relationship between intensity and the duration of the current. Determine whether a muscle is innervated or the denervated. It depends upon the number of motor units recruitment, the intensity of the current, the frequency, and the placement of the electrode. As we can see, there's an SD curve which is showing the voltage, the real base, chronaxy, the voltage and time duration taken. In normal innovation, the SD curve is of this typical shape because the impulses of longer duration all produce a response with same strength of stimulus, irrespective of their duration, while those of the shorter duration require an increase in the strength of the stimulus each time the duration is reduced. The point at which the curve begins to rise is variable, but is usually at a duration of impulse of 1 ms with constant current and 0.1 ms with constant voltage stimulator. Here, as you can see, the graph of a normal innovation. As we can see, there's a parabola. In complete denervation, the SD curve of complete denervation is when the duration of impulse is 100 milliseconds or less. The strength of the stimulus must be increased each time the duration is reduced, and no response is obtained to the impulse of very short duration. So, the curve rises steeply and is further to the right than normally innervated muscle. As you can see, the graph for the denervation. Next up, we have a partial denervation. In this, SD curve of partial denervation is the impulses of longer duration can stimulate both innervated and denervated muscle fibers. So, a contraction is obtained with a stimulus of low intensity. As impulses are shortened, the denervation fibers respond less readily. A stronger stimulus is required to produce a perceptible contraction, and the curve rises steeply like that of denervated muscle. With the impulses of short duration, the innervated fibers respond to a weaker stimulus than that of required for the denervated fibers. Kink in SD curve is seen at the point where two sections meet. The shape of curve indicates the portion of denervation. A kink appears in the curve and as the denervation progresses. Progressive denervation is indicated by the appearance of a kink. Increase in the slope and shift of the curve to the right. As we can see in this graph, there are kinks which shows muscle fibers are partially denervated. As you can see in this graph, moving on to the equipment required for the SD curve. Low frequency generator with varying pulses from 0.02 to 1000 millisecond, most moist saline pad, electrodes, LEDs, bandage, and plastic protectors. The advantages of SD curve: it is simple, reliable, and cheaper. It indicates proportion of denervation, and it is less time consuming. The disadvantages of SD curve are in large muscles, only proportion of fibers may respond, hence picture is not clearly shown. It is a qualitative rather than quantitative method of testing innervation. It won't point out the site of the lesion. Next up, the nerve conduction velocity studies. NCV is a test to see how fast electrical signals move through your nerve. The surface electrodes are placed on the skin over nerves at different spots. Each patch gives off a very mild electrical impulse. This stimulates the nerve. The nerve's resulting electrical activity is recorded by the other electrodes. And the distance between electrodes and the time it takes for electrical impulses to travel between electrodes are used to measure the speed of the nerve signals. As well as their electromyography recording from needles placed into the muscle is often done at the same time as this test. The therapeutic rehabilitation, the neuromuscular muscular electrical stimulation. Now moving on to the therapeutic effect of the EMS. The muscle fiber types, there are motor unit of HC plus alpha motor neuron plus muscle fibers. It is of slow excitative type, vascular, fatigue resistance, red fibers or ultra. Type 2, as we have already seen the type 1. Type 2 is previously called Pice fibers or white fibers. It is fast oxidative glycolytic FOG. It is intermediate, some oxidative metabolism, therefore some fatigue resistance. Moving on to type 2B, it is fast glycolytic FG. It is least oxidative, least fatiguing, resistance, highest, and the fastest force production. The neuromuscular electrical stimulation, NMES, is used for muscle re-education and prevention of disuse atrophy. It is mostly used in the patient with paralysis, paraplegia, the weakness, and loss of sensation. It is used in decreasing muscle spasm, decreasing the edema. Why neuromuscular electrical stimulation? It is used on patients who cannot perform a voluntary muscle contraction in peripheral nerve innervation is intact. Yet muscle is too weak to contract from atrophy, pain, immobilization, etc. It promotes the early range of motion in post-surgical and immobilized limbs. Break pain, spasm, pain cycle of the muscle spasm. Don't replace strength training with neuromuscular electrical stimulation because neuromuscular electrical stimulus recruits fibers in opposite order than that of a voluntary contraction. In machine, there's a large fibers followed by small, involuntary, small fibers followed by the large fibers. The patient needs to move on to more traditional weight training as soon as possible. Now, moving on to the physiological sequence in the contraction, the synchronous motor unit pattern is a smooth graded contraction. It relates to the number of motor units firing, also known as partial summation. The rate of motor unit firing is the temporal summation. Normal contraction, increase no number of motor units in early contractions to force. Then increase firing rate to increase force further. In type 1, you fire first, then type 2. Type 2B bought in a last of 4. The electrical stimulation pattern, synchronous firing pattern, all muse fire together. Type 2 neurons are larger, therefore have a lower threshold, therefore fire first, reverse of the natural sequence. The effect of the electrical stimulation, it has a short duration and a long duration, for short term and the long term. In short term, the contraction and altered blood flow. In long term, the strengthening, structural changes, biochemical changes. The mechanism most likely neural due to speed of response and lack of volume changes. Spinal motor pool activation, synaptic facilitation, muscle motor unit firing pattern changes, SO to FOG or FG. Best effects for weak muscles is 30 Hz at 300 microsecond, 2 seconds on 3 seconds of 1 hour per day for knee immobilization. Treatment group, no strength loss. Non-treatment group, 70% reduced exec area. The waveform, biphasic seems to be most effective. There are the biphasic asymmetrical and the biphasic symmetrical. Now, moving on to the intensity and force of contraction. Approximately linear relationship between current intensity and force contraction. Ferguson et al. At 89, Underwood et al. At 1990, the greatest effect with least current intensity by using biphasic pulse or burst AC current. The force of contraction, the stronger muscle contraction with 300 to 400 microsecond pulses, but this will produce a significant stimulation of sensory fibers. The stimulation frequency affect force generation. The higher forces produced with tetanic contraction, but also more discomfort and potential for muscle damage. The more especially with the patient, the tetanic stim is widely researched with athletes, fit individual rather than those with the muscle dysfunction. The force generation versus the fatigue. Maximum at 60 to 100 Hertz, Binder et al. At 1990 given that, but also get higher fatigue. 20 Hertz stimulation will achieve about 65% force, but also much less fatigue. The stimulation parameters, the duty cycle is on-off ratio. Minimum is used to equal cycles 1:1, but only for those stronger and rehab and fit patients. They use higher ratios for the weaker to allow stim with minimal chance of fatigue. The weaker of poorer state the muscles, larger rest time proportion. The might start at 1:9 for a very weak patient and progressively reduce toward 1:1. For example, if using stim for squats in a very weak patient, suppose we take a post TKR total knee replacement, might use a 1:9 ratio. So 10 seconds stim would be followed by the 90 seconds of rest. Is on ramp, the ramp up of 2 seconds, then sustaining 7 seconds, the 1 second of ramp down. It gradually increases stimulation strength at start and gradually decreases at end of the stimulation phase. The more is physiological, certainly more comfortable. No definitive work, but most use longer ramp up 2 to 4 seconds. As we have seen, the shorter ramp down is of 1 to 2 seconds, typically ramped stimulation pattern. Is in review electrodes of physical dimension. Shape is unimportant, as we all know that most are round or square or rectangular. Size and placement determine the number of motor unit or stimulated. Now, the shapes of electrode, as we see, there's a rectangular, there's a circular, elliptical, and square. The review electrode function, active electrode under which the current density is great enough to elicit the desired response. An indifferent dispersive electrode under which the current density is not too great enough to elicit the desired response. Electrodes. Best if both electrodes on muscle belly. Best if one is at or near motor point. Larger electrodes better, less current density, therefore less discomfort. Advantage if electrode placed in longitudinal orientation by Brooks et al. In 1990, given that the strong contraction with the less discomfort. Special electrodes are available for pelvic floor stimulation. Now, moving on to the strengthening protocols of athletes plus non-injured subjects. Suppose 2500 Hz burst AC, Tamanatol and Snyder-McClure in 1890, Wemsley et al. Symmetrical and asymmetrical biphasic pulse by Allen et al. 1987, Kremb et al. At 1989. Frequency usually at around 60 Hz plus stim, intensity at maximum tolerance, but can get an effect of 25 to 50% isometric. The pulse width is about 300 to 400 microsecond, may be the best. The duty cycle relates to fatigue. If less fatigue, resistance should be of 1:8 or 1:5. One less likely to fatigue drop to 1:3 or 1:2 to 1:1. The ramp has no definitive rules, but with stronger stimulation, use a longer ramp. Usually 2 to 4 second ramp up and 1 to 2 second ramp up down is enough. 2 to 15 maximum contraction session, 3:5 session, or in a week, 3 to 6 weeks for a significant effect. The strengthening protocol of a rehabilitation program, similar ideas but tend to use a lower frequencies, minimum required to get tetany to 20 to 35 Hz. Continue for longer per session and use a duty cycle which minimizes the fatigue, at least of 1:4 or more. The most effective treatment approach may employ 100 to 200 contractions per session, usually over 1 to 2 hours. Now we'll see the suggested clinical treatment parameters or muscle strengthening. It is 30 to 35 Hz at 400 microseconds. It starts from 4 seconds on and 4 seconds off, the minimum, but usually 10 seconds on or off, at least 15 minutes alternate days, but usually 30 minutes per day. It needs strong contraction, not just mild twitch, plus voluntary as well. For muscle endurance, it is 20 Hz at 400 microseconds. 2 seconds on or 2 seconds off, minimum at least 1 hour per day. Minimal contractions. For very weak muscles, marked atrophy, it is 10 Hz at 400 microseconds. 2 seconds on, 2 seconds off, the minimum. It also requires minimum 1 hour a day, and it has a minimal contraction. Now moving on to the tetanic contraction to break the muscle spasm. Our goals should be to increase the local circulation, to remove metabolic waste, to mechanically stimulate muscle fibers, to induce some muscle spasm fatigue, moving on to the neuromuscular electrical stimulation for decreasing edema. Produce cyclic muscle contraction to help the pump chronic edema at 5 to 10 seconds on, 5 to 10 seconds off. The NMES effect are muscle contraction, increase blood flow, retard atrophy development, the decrease and retard neuromuscular inhibition, decrease muscle relaxation, decrease spasm. It decreases pain, possibly by decreasing the muscle spasm. The advantage and disadvantage of NMES is see the disadvantage can be applied to immobilized body part. Disadvantage are sometimes become a panachium. The indication and contraindication of neuromuscular electrical stimulation. First, we will see the indication. It has a residual or chronic muscle spasm. Is used in any time normal neuromuscular function is not possible in muscle strains during cast immobilization or disuse atrophy, pain owing to muscle spasm. The contraindications are not used in a person with a pacemaker, over the heart or brain injury, over recent or non-union fractures, over potential malignancies. Precautions should be cautious over an area with impaired sensation, skin lesion like cuts, abrasion, new skin, recent scar tissue, decreased range of motion, extensive torn tissue. The techniques of application, we will also see the techniques for group muscle stimulation and motor point stimulation. The group muscle stimulation is a stationary stimulation. The active electrode and passive electrode will be kept stationary. Here are the some motor point stimulation. As we can see, the motor point of axillary nerve. Here we will see there's a deltoid anterior fibers. The deltoid for the middle fibers, it is at the middle belly of the deltoid. For the pectoralis major at the upper chest region. The anterior fibers of the deltoid in the front delt, as we can see in the biceps brachii. The coracobrachialis at the mostly the medial side, the short head of the biceps. As we can see, there's a long head of brachialis at the lateral side. Here's an brachioradialis. Then we have pronator teres, flexor carpi ulnaris, palmaris longus, flexor carpi radialis, flexor digitorum profundus, the medial fibers, the pollicis longus, flexor digitorum profundus, superficialis. We have abductor pollicis brevis, opponens pollicis, flexor pollicis, abductor digiti minimi, flexor and opponens digiti minimi. Here we have lumbricals. These are the motor points. And for tricep, it is at the medial head and at the long head. Here's for the lateral head, for the long hair. We have for supinator, extensor carpi radialis longus, extensor carpi ulnaris, extensor digiti minimi. We have a digitorum at abductor pollicis longus. Then we have adductor pollicis and the enterosteum. Moving on to the motor points of the musculoskeletal now. As we have seen the coracobrachialis, biceps, brachialis. Here are the motor points for the musculoskeletal now. Motor points of the radial nerves. Here you can see the brachioradialis, tricep, long head, supinator, extensor carpi ulnaris, and some major flexor and extensor group of muscles. As you can see, the motor point of the median nerve, pronator teres, FCR, palmaris longus, flexor digitorum superficialis, flexor digitorum profundus. It is LOAF, lumbricals, opponens pollicis, adductor pollicis brevis, and flexor pollicis brevis. Now we will see the motor point of ulnar nerve. The lumbricals, interosseae, flexor digitorum profundus. Here's a motor point of femoral nerve. As we can see, the sartorius muscle, which moves laterally to the medially. Here we have TFL, transfacial lata, vastus lateralis, rectus femoris, vastus medialis. Then we have palmaris longus, extensor digitorum longus. We can see tibialis anterior, the anterior side. We have peroneus brevis on to the lateral side. Extensor helicis longus anteriorly, and extensor digitorum brevis. Now moving on to the motor point of the sciatic nerve, we have biceps femoris, semimembranosus, and semitendinosus. These are the two heads of the hamstring muscles. Moving on to the motor point of the tibial nerve, we have gastrocnemius soleus, gastrocnemius in which the medial head and the lateral head, in soleus also the lateral and medial side, and flexor digitorum longus, tibialis posterius, and the flexor helicis longus. The motor point of superior peroneal nerves are peroneal longus and peroneal brevis. The deep peroneal nerve, it is extensor digitorum longus, tibialis anterior, extensor helicis longus, extensor digitorum brevis. The Y galvanic over faradic and the facial muscles. We see the motor points of facial nerve as in the temporal area, the frontalis orbicularis oculi, the corrugator superficialis. In zygomatic, it is orbicularis oculi. In buccal, rhizorius buccinator, levator labii superiosus, levator anguli oris, nasalis, orbicularis oris. In mandible, it is mentalis. Here you can see some movements caused by the motor point. Motor points of the facial nerve, as we can see, this is the frontalis, the corrugator, orbicularis oculi below the eyes, levators of upper lip. We have orbicularis oris, as we also know as dimples, rhizorius, depression of lower lip. We have facial nerve lower branch, nerve trunk at the lateral side, facial nerve, the medial branch. Next up, we have motor points of the back. We have trapezius at this point, supraspinatus, infraspinatus, teres major and minor, serratus interior, the boxes muscle, or latissimus dorsi at the medial side. We have trapezius, or we have the rhomboids, middle fiber of the trapezius, the upper fibers of the trapezius. Now moving on to the principle of the application of the slow frequency current. Receiving the patient. We greet the patient and introduce yourself to develop a good rapport with the patient. We provide them a comfortable position to sit or lay down. Case sheet reading or history taking. We take the subjective assessment of a patient with, like, suppose start with the name, identification of the patient, his age, the modulation of treatment. 6, to provide privacy. Occupation, correlate the symptoms, signs of the patient for ergonomic advice if applicable. Chief complaint is going to be like generation of a problem list, side, right or left side of the involvement, side, specific area, region to be treated, anterior, posterior, medial, and lateral. Duration of the condition, acute, subacute, chronic, treatment planning and setting. In diagnosis with the condition of the patient. Now we'll see the general contraindications of the MS are hyperpyrexia, epilepsy, severe renal and cardiac problems, cardiac pacemakers, severe hypertension, infections in pregnant women, the patient with metal implant, in mentally retarded patient, in mentally upset patient, in malignancy, eyes, anterior aspect of the neck and carotid sinus. The tray preparation or the preparation is skin resistance lowering tray. We use pillow, cotton, soap, towel, Macintosh, kidney tray, petroleum jelly or Vaseline, U-pin, sharp and blunt, clips, bottle of water. Local contraindications are the open wound, scar, local skin infection, topical infection, cuts, abrasion, eczema, localized hemorrhagic spots. Now we'll see the skin sensitivity by testing. With the patient eyes closed, alternate touching the patient with needle and brush at interval of roughly 5 seconds. Instruct the patient to tell the therapist if they notice a difference in the strength of the sensation on each side of the body. Moving on to the testing and equipment and demonstration. This is to gain the self-confidence and cooperation of the patient for the treatment. We check for mains output by using the tester. Look for any frayed part of power cord, integrity of cable and electrodes. Verify that all the knobs, controls, and apparatus are at zero. Connect the machine power cord to the mains. It lasts to 220 to 100 volts and switch on the mains. Switch on the machine by turning on the power knob. Switch off the machine. Set the timer. Keep your index and middle fingers on active and indifferent electrode to check whether the machine is working or not. We demonstrate a muscle contraction to the patient by placing electrode on therapist's hands. Next up, we have the positioning of the patient. To place patient in a well-supported, comfortable, and relaxed position. Use of adequate pillows, towel, and bed sheet. We expose the body part to be treated. Have patient remove all jewelry from the area. We trap the untreated part of the patient to preserve modesty, protect clothing, but allow easy access to the body part. If possible, give the position in which patient can see the treatment. Next, we do have appropriate walk stand position. The position of therapist. The therapist should be close to the machine for operating the machine and also near to the affected side of the patient. If possible, the therapist should position herself or himself so as to observe the face-to-face patient. The preparation of the part to be treated, skin resistance lowering, uncover the part to be treated. Clean the area with water and soap to remove any oil, cream, gel, or dust. We use Macintosh and then towel for supporting and wiping of the water. Wipe the treatment area periodically with saline water or better current reduction. Instruction and warning to the patient. Instruct the patient not to move the treatment part and not to touch the power cord and the generator. Not to sleep during the treatment. We inform the patient that she should feel a mild prickling sensation. If it is too intense, should immediately report to the physiotherapist. If there is any burning sensation, immediately inform the therapist as it might lead to burn. Inform if the position is not comfortable. The application of treatment. Select an appropriate method of treatment. Make sure the power cords are not touching to the patient and not touching to each other. Select the current. We select the parameters. We set the treatment time. We gradually increase the current. The patient must be observed throughout to ensure that the treatment is progressing and satisfactorily and without any adverse effect. The termination of treatment starts with to reduce the intensity gradually to zero. Switch off the machine and the main supply. Remove the electrodes and clean the patient. Inspect the treated part of any adverse reaction. If is there any mild erythema, apply powder. If it is too severe, summon the physician or advise the patient to go to the physician. Set the next appointment and do winding up the procedure. Next, we have the recording. We kept an accurate record of all the parameters of treatment, including the region treated, the technique used, the dosage, the time, and the resultant effect of the muscle must be made. This is both for follow-up assessment and purposes for the legal requirement. This is all about the electrical stimulation. Thank you.